My name is Peggy Rauman, and I'm a registered nurse and a nursing consultant here at the College for Policy and Practice. But it is with great pleasure today that I welcome back Debbie Curtis. Debbie is the Provincial Mental Health and Addictions Consultant with the Department of Health and Community Services. She is currently the lead consultant for the Provincial Opioid Dependence Treatment Program and the Provincial Alcohol Action Plan. Debbie is a registered social worker who has worked as an addictions counselor and a disability management consultant. With her today are Bonita Kenway. Bonita graduated from nursing in 1990 as a nurse practitioner in 2004, and her Bachelor of Nursing in 2012. She has mainly worked in rural Newfoundland and Labrador in a variety of areas, including primary health care, emergency, occupational health, and addictions. As well, we have Jennifer Patrick. Jennifer is a nurse practitioner with the Opioid Dependence Treatment Hub in St. John's. Jennifer finished her nursing in 2003 and completed her master's through Athabasca in 2010. She's worked in numerous practice areas as a nurse practitioner, including primary health care, an acute mental health eating disorders program, and mental health and addictions. And she's also obtained her certification through the Canadian Nurses Association in psychiatric and mental health nursing. And Brenda Kennedy is a registered nurse and coordinator with the Opioid Dependence Treatment Hub at Labrador Grenfell Health. And she has been working as a registered nurse with Labrador Grenfell Health in various roles since 1996, with the last 10 years in mental health and addictions. And we do have Diana Douglas online too. So it is with great pleasure I pass it on to Debbie. Debbie?
Thank you, Peggy, for that great introduction, and thank you everyone for coming today. It's a great pleasure to be here with the group of registered nurses and nurse practitioners. We've always said that nurses play a key role in the field of addictions medicine, and we have many examples of it, and you're going to hear from 4 of them today. I feel a bit of the odd person out being a registered social worker, but I have always had great regard and worked a lot with registered nurses over the years. So it's okay, I hope. I'm really happy today to share with you some of the work that we've been doing in addictions medicine and how the registered nurses community has played a part and how they can continue to play a part. So I'm just going to give a brief overview of some of that work, and then I'm going to pass it over to your colleagues on the line today. So just, I'm going to start with opioid dependence treatment and just talk about the history of, we call it ODT in our province. And it wasn't too long ago that there was a very limited number of physicians who were methadone prescribers, and nurse practitioners were not prescribers up until a few years, just a couple of years ago. We had very limited access to opioid dependence treatment in rural areas of our province, several months waiting list for the treatment centre that was here in St. John's. And in Western Health, there was a clinic operated with a registered nurse, with the physician attending via telehealth from St. John's, from Central Newfoundland. So that was our history. And in terms of addictions medicine, beyond opioid dependence treatment, there was a handful of physicians who were providing this care, and then addictions counselling was being provided through the regional health authorities. Then we head towards recovery, which is nothing new to most of the people on the line here today. That was our 5-year action plan from 2017 to 2022. And in that action plan, which was intended to transform mental health and addiction services in our province, we had 3 recommendations that were specific to addictions medicine, and they're here. And one of them was to increase the number of physicians and nurse practitioners and providers involved in addiction medicine, also to look at harm reduction as a foundational approach to care. And then the third was to support the implementation of the opioid action plan. So all 3 of these recommendations were successfully completed under Towards Recovery. And one of the recommendations, other than these 3, was, before I get to that, in terms of opioid dependence treatment, we launched a provincial hub and spoke model in 2018. And this hub and spoke model was a collaborative team approach with nurse practitioners, registered nurses, addictions counselors, case managers, pharmacy, peer support workers, and physicians in our province. And each region had a regional hub for opioid dependence treatment. And the focus was on providing evidence-based care to people with opioid use disorder with no wait times, which was really key to the success of this program. So the hub and spoke model had the main part in the center was the person with opioid use disorder, and then there was three components. The hubs, which, as I said, was the team-based approach, and they're situated in St. John's, in Gander, Grand Falls, Stephenville, Corner Brook, and in Happy Valley Goose Bay. And virtual care is provided. So through those care, people have rapid access to treatment, same or next day service that they can rely upon. And over the past, since the establishment of the hubs, there's been hundreds of people who have been served through those hubs. We also have the spokes, which are the primary care providers in the communities, which have been providing, some of them have been providing this care for a long time, a number of years, and others are new to the practice. And so the spokes are those physicians, nurse practitioners who are providing care, and they at times rely on the hubs for support, whether it's for addictions counseling, case management services, and in some cases it might be to help if a person needs additional support or in terms of their initiation on opioid agonist treatment. And then the third area is the Provincial Centre of Excellence for Opioid Dependence Treatment, which was established as well in 2018. And that group has been providing knowledge exchange, knowledge transfer, and their focus has been on the workforce development and increasing the capacity of people involved in this care, and specifically healthcare providers and also people with lived experience. So one of the, under Towards Recovery, one of the recommendations was the development of a provincial alcohol action plan. So this action plan was released in July of 2022, so just this past summer. This action plan is a 5-year plan as well. And this plan is focused entirely on addressing alcohol-related costs and harms in our province. And it will be no surprise to anybody on this call that alcohol-related harms are quite significant in our province. Alcohol plays a big role in many cultural and social events in our province. This has a strong presence at many events in our province and on occasions. However, and for most people, there would not be harms related to that, but for many there are. And for this alcohol action plan, we'll be focusing on 3 primary areas. Number 1, we'll be looking at prevention and promotion, looking at helping people understand low-risk drinking guidelines, as well as focusing also on stigma and the impact of trauma on alcohol-related harms. We'll also be looking at the continuum of treatment and care under the alcohol action plan, and that will be something that I'll talk about now in a second. The third area is availability, and this is the area where we'll be looking at the things like people's ready access to alcohol in our province. We have the highest number of retail outlets per capita, but per 100,000 population, in the country, and also looking at things like marketing and advertising for alcohol. So one of the recommendations is to look at how we can expand the regional opioid dependence treatment hubs to provide rapid access to treatment for all substance use disorders, including alcohol. And as well, under this recommendation, we'll be continuing to increase the number of providers who have the knowledge and skill in addiction medicine to support those hubs on an ongoing basis. So that is just the context, I guess, that I wanted to provide here today. Before and now want to hand it off to Bonita, who's going to talk about the role of nurse and nurse practitioners.
At the hubs, the focus is in holistic care, and as nurse practitioners, we provide holistic care pretty much regardless of where you're working. But I've never been so working so closely with a group or population where the social determinants of health play such a major role. in their care and the treatment that you provide, because the addiction doesn't exist alone in itself. There's so many factors. All the social determinants of health have a great impact on the person and on the addiction, and consequently their recovery. Primary health care takes in the mental health of it as well as the physical. As you see a person in withdrawal, you see the physical symptoms, the sweating, the aches, the tears, the yawns, their skin is crawling. So you see all the physical aspects of it as well. And then you kind of, you can peel away and you can see the mental health and the trauma that's associated with it as well. That usually comes in time once a rapport is built with the client. But it's so there, and it's there, but it comes out eventually. So it's a whole encompassing. We do a harm reduction approach to care. And I think that's a big hurdle for a lot of nurse practitioners and a lot of providers, is just to wrap your head around the fact that we are in a harm reduction approach. We can meet the client where the client is, not where we want them to be. Where we want them to be, hopefully we will get them there. But in seeing in their own time. And if that's not where they are, that's not where they end up, then that's fine. But the harm reduction approach is really necessary to meet where they are, to help them where they are with their addiction, and hopefully to see beyond that. And consequently, that's why they do come to the clinics, to the offices. First thing they'll say is, I'm done with this. I'm finished with it. I want to be better. I want to be a better person. But in keeping with the fact that harm reduction is still a big part of their lives, and you got to work with that. Fulfilling work is, oh my God, it's astronomical. When you can see the person, as I just described earlier, you can see the rapid transformation for people who respond to the medications. When they come in, they're physically unwell. They got the worst flu ever, COVID 100%. It's not, but that's how they feel. They had the teary eyes, the runny nose, the yawning, the aches and pains all over their body, the anxiousness, the irritability, the agitation. I don't know if there's a single bodily system that's not affected. So when you give the Suboxone, the methadone, the Suboxone more so, it's quite superior, and you see them like an hour or 2 hours later, it's a whole different person. And then when you see them even the next day after, a full 24 hours, which are maybe still not up to the medication amount that's required for them, the transformation is unbelievable. They look totally different. They're dressing different. They're coming in with a different perspective, a different outlook. And it's, to see this transformation is something new, is something different than what you're working in primary health care. That's not to dismiss primary health care, because it's 100%, where it's at. But this transformation is just so fulfilling. And to ensure that transformation continues, you work with a multidisciplinary team, especially with social workers with the addictions counseling piece of it, because it's 50-50 to ensure that you give the person the best response, best recovery for their addiction. It takes a team for sure. And not only within, your own hubs, be it, your nurse or your social worker or your LPN, it's the whole community. You're working closely with the pharmacist. You build up a really good rapport with the pharmacist, with other providers in the community, such as other physicians. It's just so encompassing, and it's so rewarding. And, yes, you do have some relapsing, but you help those people with those relapsing. And, there's such a bond between the nurse practitioner, I find, and the client that it's pretty strong. It's really strong, but it's very, very fulfilling work.
Bonita was one of the first nurse practitioners working in the hub, so I really appreciate all the experience that you bring to the table, Bonita, today, and I'm sure we'll have a chance to check in again now with some questions later.
Sure.
I'm going to hand it over now to Jennifer, who's going to talk about the potential obstacles and challenges, but how to overcome them as well.
Thanks, Debbie. So the first one that comes to mind when you look at potential challenges when working with our clients is if they feel that they're facing stigma, they won't even engage in treatment, or they might leave treatment too early. And as clinicians, it's important to realize that this possible stigma could be betrayed by our language, using the terms such as addict, junkie, drug abuse, those kinds of things. Unfortunately, can also be conveyed by behavior, such as ignoring a patient's withdrawal-related pain or discomfort, or even through attitude. There's people that might believe a client deserves the suffering they're going through with the addiction. So it's very important that we use neutral terminology and say things like injecting heroin instead of shooting dope. Use person-first language. So say person with a substance use disorder instead of addict. I know within my practice, if I'm talking to clients about sharing straws, for example, I might say, if I had HIV and then you use my straw, then I could pass on the HIV to kind of normalize it for the client, to make them feel like there's no judgment within the practice. Medify is an organization out of Ontario, and they have further resources about that. It's called stigmaendswithinme.ca if anyone's interested in that. Also, unfortunately, people tend to view substance use disorder as a moral failing or a choice, and working within this population, you come to learn that that's not true. Of course, there's a diagnostic criteria in DSM-5, and simply put, the Canadian Association for Mental Health says there's 4 C's of substance use. There's people that have cravings, they lose control over the amount or frequency that they want to use, they feel a compulsion to use, and they use despite consequences. And it's also important to have an appreciation that substance disorders are quite complex. There's many causes and risk factors for substance disorders. Just a few would be, there's genetic factors. People can be predisposed to developing a substance use disorder. A second one would be how substances interact with the brain and how people react to that feeling of feeling good and the release of endorphins. Also, people's environment greatly influences their substance use. How it's viewed within their home and their community and their peer group can influence whether or not a substance use disorder might develop. Also, another thing to give consideration to is that if a client has a mental health diagnosis, they could be more predisposed to substance use as a way of coping. And also, clients might use substances to cope with thoughts and feelings. And unfortunately, a great number of our clients have lived through traumatic life experiences. According to an article from the Canadian Family Physician in 2020, people with substance use disorder have a higher prevalence of PTSD, and it can range anywhere from 15 to 42%, which is about 10 times more than the general population. Trauma often precedes substance use, and they're using it as a way of dealing with the trauma. And they also have an increased chance of being exposed to violence or trauma when using substances. So with that in mind, it's important that within our practice, we offer trauma-informed practice, be aware of the trauma, offer choice, collaboration, and connection. Create an environment that the clients think is safe and that they can trust you, and help with skill building, and take a strength-based approach is also important. The next thing I was just going to briefly touch on is the licensing requirements, because they do seem to be quite complex and can take a great deal of time. Before I got into that, I thought it was important to share a quote from a client that was in recovery, which says that recovery is something that you have to work on every single day, and it's something that you don't get a day off from. So I just thought it gave perspective for us and engaging in this stuff. It seems like it's complex and stuff, but if you look at the work the clients are doing, ours is not near as difficult. So right now you have to participate in the provincial drug prescription monitoring program, and that's looking up prescriptions on the NLPD, the Healthy NL, sorry, and getting the tamper-proof pads. One thing that has changed is that you can do the course through a university in BC now, as opposed to the one in Toronto, from when I got my license, which is awesome, because that one isn't like at set times of the year. You can just get in on at any time and participate in that course, and I believe it's free of charge. There's the Suboxone modules as well. And everyone has to do 2 days of clinical training. And certainly if you're within my area, everyone's welcome to come and spend a few days with us. I have to say we enjoy that. And also one thing that's changed is you don't have to get the certificate from CAMH as you did previously. It's just recommended, which is also nice because it does take a great deal of time. And I know cost can be a perceived barrier as well. I don't know if you have anything to add about that, Debbie. I know sometimes the Center of Excellence offers some funding and stuff.
Yes, we've, in order to increase the number of practitioners involved, we have offered some subsidies over time. And Jen, I'd just like to say, I guess that, the number of nurse practitioners have been steadily increasing. We're now at 18 nurse practitioners who can prescribe Suboxone, and 16 of them can also prescribe methadone. So that's grown. I mean, that was only 6 people, I think, 3 years ago. So
I was going to say it's definitely increased in the last couple of years.
It has.
One thing that can be a barrier as well is a feeling of responsibility with ordering these medications. You do all this training and you get there and it's time to order it and you're like, well, what if I mess it up? And you've done, like I said, you've got all this additional training and stuff. And then our clients, as Bonita had said, are so complex. They come in and they could have issues about housing or income support. Drug coverage is a big one. They might not even be able to afford the medications that you're ordering. And so all that rests with you because you're thinking, well, if I order the wrong thing or don't help them access it and then they don't get into treatment, that all plays on your mind when you're ordering the medications. But a big part of that is it gets easier with time and you get used to the complexity and helping the clients. And there's a lot of supports available. There's certainly myself and Bonita around for questions and any of the other NPs that order it regularly. I know my team has been one of my greatest supports. We all bring different disciplines to the table, and when we discuss things, they might see things differently than I would or be able to help in a certain situation that I wouldn't think of. As I mentioned earlier, there is MediFi, which is an organization out of Toronto that helps to deal with addictions, and they're a great resource. There's provider guidelines on their website and all that stuff as well. And they also have a listserv where you can sign up to get emails, and it's many emails daily, but it's about different topics related to this stuff and helping out. Like yesterday, one of the topics was the perioperative management of Sublocade, which is something that you might not have experience with, but is great to know about when the time comes and all that stuff. Another perceived barrier with regards to our clients is, unfortunately, people seem to believe that they'd be more likely to engage in violent behaviors. I didn't look up a lot of stuff about that because I have to be totally honest. I've worked here or at recovery since 2018 and maybe had a threat of physical violence twice in that time frame. And I'm not saying it doesn't happen, but it's very rare and probably no more frequent here than with any other population in my experience. And the continued relapse of our clients could be perceived as a barrier, but it's part of the illness and unfortunately will occur. But I have one client now and I think we're on the 8th start, and I'm just happy that every time that client comes back and wants to try again.
Thanks so much, Jen. And Jen, in her practice at the Opioid Dependence Treatment Center in St. John's, has provided a lot of support to groups around, including the penitentiary, when they were starting to initiate, the nurse practitioner there was starting to initiate people who were incarcerated. And that was a new development over the last year or so, and through your support, Jen, that was made available. So thanks for your presentation today, and again we'll likely get back to you again. I'm going to turn it over now to Brenda Kennedy, who is and Diana as well, who Brenda first is going to talk about her role in harm reduction and her role on the team in Lab Grenfell Health.
Hi, my name is Brenda Kennedy, and as Debbie said, I'm the registered nurse with the Opioid Dependence Treatment Program here in Labrador Grenfell Health. We provide harm reduction approach when it comes to the dependence treatment program, and we also have the SWAT program, the Safe Access. So we have safe supplies here as well. We focus much all our practice meeting the clients where they're at. We don't, portray our goals onto them. It's their goals that we help them meet. We might think we know what they need best or what's best for them, but we need to meet them where they're at, and not where we found them. Our favorite quote is meet them where they're at and don't leave them where we found them. So they may come to us at the hub. They're not ready for the treatment, but they are ready for something else, and that could be safe supplies. We will give them safe supplies. There's injection kits, crack cocaine kits, sorting kits. So that's our approach with them. And when they come in, we treat them with the most dignity, respect, because they have a disease just as anyone else that would be coming into the hospital looking for care. So we make sure that when they come in to see us, that they feel quite comfortable, and understanding why the addiction, it's often go back to trauma. So we try to stay trauma informed to help us understand the addiction. And as I said earlier, we help people meet their goals or share goals one at a time, and we do that in a collaborative approach. We have myself as the registered nurse here, our nurse practitioner, counselor, and she does some great work with clients. So she helped them reach a lot of their goals, and that could be something from getting support so they can get an LDP to cover their medications, or that could be coming in to get safe sex supplies or coming in to get meals. So it's their goals that we help them meet, and not ours. And I have to say, in my 26 plus years of nursing, I've been around quite a while. I've worked in various areas: the operating room, inpatient, long-term care, mental health addiction. And my role with the ODP program is by far the most rewarding for me in my career so far. If anyone has an opportunity to work in this area, I think everyone should, was as a student or as the nurse in that area. It changes you as a person, or for me, I think it me not only a better person, but a better nurse to work with people in this field. So I do highly recommend anyone who wants to go in this field to definitely take on. It's a great role. It's very rewarding. I think it's best. I'm going to retire here. Not happening yet.
Yeah, I've heard Brenda talk many times about her passion for this area of practice, and it's great for you to share that today, Brenda, with your fellow nurses about that, the importance of this area of practice and what it's meant to you in a nursing role. And I've heard other nurses say that as well, other nurses who've had long careers in nursing. So it's you're real champions for this work for sure. Diana, I know that you wanted to talk a little bit as well about the diverse area for practice that you've found in your work. So I'm going to hand it over to you now.
I'm Diana Douglas, and I am the team lead for the Western ODT Hub. I've been in mental health, I've been nursing about 15 years. The majority of that being mental health and addictions. It's definitely my love. I most recently, I guess, I've been all over in mental health and addictions, but for the last 7 months, I've been with ODT, and I just find it such an exciting area of healthcare to be in right now. It's expanding so quickly. The need for services is growing at such a fast pace. It's just such an exciting place to be. It's so different from your regular bedside nursing roles. Or I guess traditional bedside nursing, where we used to typically, you treat the problem, but not necessarily what's causing the problem. So we send people back out feeling better, and they come back in again with the same issues because we weren't looking at it, I guess, the way we are now with the harm reduction approach. And it's really diversifying the profession and giving us more opportunities for different roles, different things. Who'd have thought a nurse could work from home? With approximately 1 in 5 Canadians aged 15 years or older experiencing a substance use disorder in their lifetime, it's the need is just so obvious, and it's there. Since the 80s, when opioid use disorder emerged, it has been growing exponentially. And of course, it's a piece of a much larger picture in terms of such a wide range of substance use and co-occurring disorders. No matter where you work in nursing, even if mental health and addictions isn't your focus, you're going to come across it, you're going to see it. And it's just, I think it's so important for everyone, for all nurses, to take an interest in it and to learn about it, so that I guess we can all be part of the change. That's it for me. Thank you.
Thank you, Diana. Diana was talking about that emerging field in addiction medicine. And I think, it's really important for me to mention today how nursing has played such a big part of that in Newfoundland and Labrador, particularly with opioid dependence treatment. And I think going forward for addiction medicine even broader. And I just have to use the example of Sublocade, which is a fairly newly approved medication in opioid dependence treatment. It's a form of Suboxone, but it's a monthly injection. So many people are aware of, people every day have to line up to get methadone or Suboxone, but the monthly injection has been life-changing for so many people who don't have to travel an hour in every direction, in both directions, to get that medication. And it's been the nurse practitioners at the opioid dependence treatment hubs who have led the way in our province with providing that care. Physicians are providing it as well, but our hubs have really taken the lead and provided that level of service. And it's again, that is a real life-changing service for clients. And with Sublocade, they don't have to be stable too long on Suboxone to be able to get that service. And so it's a credit to the nurses and nurse practitioners who've taken on that role. We've talked in her presentation, Jen talked about reducing stigma and discrimination.